a little bit of housekeeping first. If folks could log into the CME system and log attendance, it really helps us both keep track of attendance at lectures, as well as hopefully one day provide food at lectures and support the IT portion of this lecture series. So I believe Melissa Hood has posted a link to the chat. So if you wouldn't mind jumping in there and logging your attendance, even if you're not claiming CME, it would be much appreciated. So today it's my pleasure to introduce Dr. Holly Depinet. Dr. Depinet earned her MD at Wake Forest, went on to complete a pediatrics residency at CHOP, and then a pediatric emergency medicine fellowship at Cincinnati. Since that time, she's also completed 2 courses in quality improvement at Cincinnati as well. She is currently joining us from the University of Cincinnati in Cincinnati. And I was going to turn it over to Dr. Chambers, maybe to touch on some of her quality improvement work and also kind of fill in the gap. So Dr. Chambers.
So we are so honored that Dr. Depinet made the time to be with us today. I have known Holly a really long time. We were fellows together. I think 2006 is when she got there. And from the first time I met her, she is one of the most compassionate, detail-oriented, devoted physicians and colleagues that I have ever worked with, and her devotion to detail and to patient safety has really blossomed, and she is an incredible improvement scientist as well. And so I have learned so much from her about sepsis, about how to design a system that is very responsive to early indicators of sepsis, and patient safety as far as how to do patient safety follow-up reports, and also, again, just how to continually beat the drum of system solutions to patient safety problems. So she has a wide variety of skills, but one of them is definitely quality improvement and sepsis. And so I'm going to turn it over to her, and with much thanks for her making time in her schedule.
And I do apologize, Dr. Depinet, your audio is currently cut off. And just for everybody watching, there seems to be a glitch in Zoom where the audio kind of cuts off spontaneously. So if that happens during the presentation, we'll kind of interrupt and get back on track. So.
Thanks, Hal. Is it back?
Yes, it is. We're good.
Okay, terrific. I apologize. I had the dreaded computer refresh 2 months ago, and I thought this problem was solved, so I apologize. So thank you again for inviting me today. As Dr. Chambers said, my interests are in quality improvement, specifically around pediatric sepsis and patient safety, and I'm honored to speak today, and I'll be focusing on systems-based care for sepsis.
Do you think that's how they get?
It's cut out again, Holly.
Dr. Depinet, your audio's back off.
I sent her a chat. I'm not sure if she can hear us speaking or not.
Dr. Depinet? Hey. The audio.
Dr. Depinet, do you hear us?
I hear you now. Yes, I do.
Do.
Is
okay.
Is that better? Sorry.
Yeah, we didn't hear anything other than your very first sentence, maybe. So.
Okay.
And it seemed to cut off when somebody's microphone, I think, was briefly on. So maybe we'll make sure all the other microphones are off, and that may kind of be the source of the glitch. So
I may leave it on. I will leave it on this view as well, so I can quickly turn on and off if that's okay for just a minute. Can you see the slides well enough?
Yes.
You can. Okay. I am so sorry about that, guys. So again, thank you. Thank you for inviting me. I will be focusing on quality improvement for pediatric sepsis. I know you guys are working on some QI work around a sepsis system. And so I'll really try to focus on how to tailor things to this system. And I will start with a brief, I'll go up so you can see that part. I'll start with a brief review of the evidence around individual care for pediatric sepsis, but the focus really will be on developing and tailoring a system. So to start with some background, we know pediatric sepsis is a big problem, both worldwide and in the US, both in terms of burden of disease as well as cost, as well as mortality. And the mortality estimates really range from 2% to even 25 to 30%, depending on the environment and the population. We know there's evidence-based guidelines and have been for a while, and we know they exist and they can improve care and improve outcomes like mortality, but we also know that for a number of reasons they're really challenging to follow, and pretty much almost no one reliably follows them. And so as a result, under recognition of shock, delayed recognition, delayed resuscitation really has been a theme in serious safety events nationally. I feel like everywhere I've worked and everyone I've talked to from dozens and dozens of hospitals has a case or cases where for whatever constellation of reasons, it was just difficult to recognize and figure out until it was too late. And so, this is definitely a problem that we all share. And so why the increased interest now? A couple things. I think, pediatric medical care is increasing in complexity. There have been some high profile cases and some resulting legislature and more attention from, like regulatory bodies and things. And then there's also some fun new tools to leverage, like multi-site collaboratives, proteomics, machine learning, those kinds of things. And so even though there isn't like one new fabulous sepsis drug, there's a lot of other sort of new tools in our arsenal, and people are excited to explore those. And so what exactly is pediatric septic shock, especially when I'm talking about it today? What are we talking about? So some definitions were proposed in 2005 that were pediatric specific. They were based on SIRS criteria plus infection plus impaired perfusion or cardiovascular dysfunction. And they were very thorough and detailed, but mainly meant for the research arena and are really best sort of applied there rather than looking at a patient that just came in, from home. In 2016, some adult definitions were proposed, and there's studies underway trying to figure out how those apply to kids, but they haven't really been validated yet. And then we also have sort of the chicken and egg argument around pediatric sepsis. If we do some early interventions and the patient gets better, is that because those interventions were helpful, or is that because, the patient was fine, they never had sepsis, and the interventions were unnecessary? And so do we aim to target those kids with our interventions? Do we not? Do we aim to research them? Do we not? And especially in settings that see kids for their initial care, that's always sort of a big challenge. So for today, because we need to know what we're talking about, I'm using the definition that the Pediatric Surviving Sepsis 2020 campaign used. And I'll talk about their evidence in a minute. But essentially what I'm talking about is just generically severe infection leading to cardiovascular dysfunction, such as hypotension, vasoactive agent need, impaired perfusion. And, obviously with the huge caveat that when the patient walks in off the street and at the time that you really want to make a difference in care, they may not have this. They're not walking in saying, I need an epinephrine drip. They are not walking in hypotensive maybe. So sort of looking at a clinical entity from its end, but trying to address it before that end happens. And so while the definitions have changed over time, the evidence has evolved as well. And I'm definitely not going to go into super deep detail about all the initial studies, but I think most of us are kind of familiar with the idea that, initially in both adults and kids, there was lots of trials that supported, early rapid fluids, fairly aggressive targets. Some of those, especially the targets in adults, were shown to be less helpful. And then some studies sort of questioning what is the benefit of, this much fluid this fast. And then some QI studies came out, and then, so where are we? We have all this stuff and some of it's new and a little bit conflicting. And as early as really like 2016, 2017, in addition to the individual guidelines, and this is the Society of Critical Care Medicine's pathway from, I believe, 2015 to 2017, they were starting to really recommend, in addition to what you're thinking about when you're looking at your patient, you also really need to think about your system. And they said their major new recommendation is that the hemodynamic supportive septic shock should now be addressed at the institutional level. And I really love that statement. And it's sort of the basis of all the academic work I've done for the last, 5 or 6 years. So I hope I love that sentence, but I think it really gets at what we couldn't do at the patient level, we maybe can do for the patient at the system level. And so they recommended what a few of those pieces of the system are. And I'll sort of spend the rest of today talking about, how at Cincinnati, as an example, we have done some of those pieces of the system, but also showing, how others have done it or how it could be done differently or thought about differently. Because one of the really interesting things about this is, there's these pieces that need to be in place, but they don't have to be identical. Everybody doesn't need the same screening tool. Everybody doesn't need the exact same sepsis pathway. What you need is the one that will work for, your area and your processes and your people and your patients, and that may be different for different areas. And yet sort of it seems to, if you put those pieces together, work, even though everybody has a different detail. And so the three things they recommended were, a recognition bundle of some sort to figure out earlier who has sepsis, might have sepsis, is at risk of sepsis, some sort of indicator of who might we need to target a little more closely. A resuscitation or a stabilization bundle, or some people would say a pathway or a protocol. And I'm using those words, broadly. I'm not talking about resuscitation as something that is necessarily done in a trauma bay or an ICU. This could be done and frequently is done on, hospital floors and regular ED patient rooms and oncology day clinics all the time across the country. So by resuscitation, I just mean early care. I don't mean something that takes a ton of resources. And then they also recommended a performance bundle, which is sort of the QI piece to monitor and support that best practice. And so where did those three pieces really come from? And so I'll take a step back to go over that in a second, but did want to show the Pediatric Surviving Sepsis 2020 guidelines, just because I think they're actually really helpful. If you Google Pediatric Surviving Sepsis 2020, the webpage will come up and it's all on there and available. Their full long document. They have an executive table of 77 recommendations. That sounds like a lot, but is actually really quick to read through. It gives some detail and it gives level of evidence. So it's actually a really nice way to get yourself up to speed on current sepsis recommendations in under half an hour. And then they have a nice algorithm here where they sort of divide things into, kids with clear septic shock, clear cardiovascular dysfunction, and then a new category of kids, which I think is really nice and helpful because we all have kids that we think might have sepsis or might not, and just need maybe a bolus or just need some Tylenol and diagnostic evaluation and a little more time to figure them out. And so they have for kids without organ dysfunction or where you're looking for organ dysfunction, but they're not clearly in shock. They have recommendations where you have a little bit more time to figure it out, but still providing appropriate care. They also then divide the fluid recommendations specifically into healthcare systems with intensive care and healthcare systems without intensive care. And, when we say intensive care, we really mean sort of any healthcare system or hospital, in a mostly, high resource country or setting. And we have one of these, like we have a satellite hospital that doesn't have an intensive care unit. And, in no way is that a healthcare system without intensive care. We're really, when you say that, you're really talking about a patient in an area where you will probably never be able to get a ventilator or or vasoactive agent support, even if you wanted it. So really talking about mostly overseas. So today I'm only talking about the healthcare systems with intensive care because I think that applies to sort of anything in, certainly in the US in terms of you can always transfer and get that. And so what are the highlights? Like I said, there's 77 recommendations, so I won't talk about all of them today. I think they're all worth a quick read. But the highlights are, for antibiotics, like I said, they differentiated this into, kids with clear septic shock, get empiric broad spectrum antibiotics in as soon as possible and within an hour. And then for kids where you're suspecting sepsis or you're finding some sepsis associated organ dysfunction, but no shock, you have a little more time to, think diagnostically and figure out, which antibiotic or if antibiotics are needed, but then still aim for within the first 3 hours. For fluids, and I wanted to go over this a little more carefully because there's lots of questions about, is this different? Is this not different than old recommendations? So they suggest 40 to 60 mLs per kilo over the first hour in aliquots of 10 to 20 per kilo at a time. They suggest, although it's not a strong recommendation, crystalloid like lactic, like ringers or like plasma-lite. They suggest crystalloid over albumin and then balanced or buffered crystalloid like lactated ringers or plasma-lite over saline, although that is not a strong recommendation. And a lot of sites, including sites that have been involved in these guideline developments, still sometimes use normal saline for their first boluses or are doing a study comparing the two. And then just a few other things that I thought were clinical highlights. They suggest against using exam alone to categorize warm or cold shock, just because the physiologic profiles of patients are frequently not as clear cut as that. They suggest using epinephrine or norepinephrine instead of dopamine. And they suggest the timing of that to be reasonable after the first 40 to 60 per kilo of fluid resuscitation, if abnormal perfusion or hypotension remains, or sooner if there's signs of fluid overload. They do not recommend one over the other differentially. It really is based on, the system and what you have available and what you're most sort of comfortable using. And so I think most people in systems sort of try to pick one as their first line just for safety of dosing, and they really are equivalent. They also mention that both are acceptable to start initially in a peripheral line, which was helpful. They also suggest against using etomidate as the intubating agent, and they suggest a trial of non-invasive mechanical ventilation. And so, like I said, that's a few of the 77. There's lots of really good stuff on antibiotic stewardship in there. There's lots of really good stuff on further advanced care, but just wanted to give a highlight of the stuff that sort of applies to maybe developing a sepsis system down the line. And then my favorite part of their recommendations are sort of their systems-based care. So they recommend screening, suggesting, implementing systematic screening for timely recognition. And the tools, again, there's, been a number of them published, and I'll show some examples later. But they really need to be tailored to the patient's resources, institutions, workflows in order for them to work. And no one tool has been shown to be superior to another. I'll mention a couple common ones that people have liked, but there is definitely not evidence that, XYZ is the sepsis screening tool to use. Most of these tools do prioritize sort of evaluation of a screen positive patient, but still leave the treatment decision with the clinician. I think there was a few early tools where people would just start orders and pathways based on a positive screen. I'm not aware of any hospital that does that at this point. Most people have, a screen and then a huddle and then a decision. And then the next step really is, whether we call it a protocol or a pathway or a bundle or an algorithm. And those all have slightly different meanings, but really the idea is to have a systemized way of providing care for and the initial interventions as well as reassessments for kids with sepsis. And the reason for this recommendation is that it improves the speed and reliability of care and has been shown to improve outcomes. And the focus really is on sort of just this timely bundle of care, although the bundle has been shown that sort of the sum is more important than the parts, and that the parts can differ a little bit. And so that recommendation really came out of, there was 3 or 4 hospitals that starting about 10 years ago did this combination of, you screen a patient with some type of tool, and that these 3 hospitals used very different tools than each other. A patient who had a positive screen had a rapid team-based assessment. And then if the team determined there were signs of sepsis or shock, were started on a standardized care pathway. And again, the screens differed enormously, the huddles differed enormously, and the pathways differed a decent amount. And yet over time, all 3 showed impressive changes in mortality, which at a single center for sepsis is actually pretty hard to do because individual mortality is so low. But they also showed, improvement in days between death and improvement in acute kidney injury and the need for dialysis when they did this kind of X plus Y plus Z, X, Y, and Z being screening, team-based huddle, and standardized care. And all of these were supported with QI methodologies. So I'll talk about that in a minute because that's sort of a piece that I think of as like encircling that other picture. So wanted to give an example from Cincinnati Children's. And so we initially started our work back in 2013, and you can see from these first 3 areas here that that we started our work like a lot of people did in the emergency department, just because that's where a lot of the initial systems-based care studies were done. And we implemented a series of screenings, huddles, pathways supported by education and other resources, and had some nice improvements in outcomes in terms of deterioration. And then as sort of the concept of using the systems-based care sort of took hold nationally and collaboratives were formed, we joined part of the Improving Pediatric Sepsis Outcomes Collaborative, which is a current ongoing collaborative of about, I think, 45 hospitals. It's across the whole hospital for those who have joined. And we have, continued to do work there. And I'll kind of talk through how we how we started the work, how we, recruited people, understood our local data, developed an algorithm or a pathway that really worked for us, including our own sort of local expert, involvement in that, piloting in some of our more sort of high acuity units, and then spreading to other units, and then really finally implementing in terms of hospital-wide and really integrating in the other hospital safety systems. And so I just wanted to take a step back. I think probably everybody's familiar with this, but we really used the QI approach for this. There's a picture here of the model of improvement where we said to ourselves, what are we trying to accomplish? How will we, identify an improvement, and how will we, know that we made an improvement? And so started with, our scope and our charter, documented our current state, and I just put a little picture there to remind everybody lots of ways to do that, but a failure modes analysis is one of them. Defined some aims and measures, developed our theory of improvement, which is really the part where you think about your system and you think about what the problems are and you think about what can I do to change or fix these. And so we used a key driver diagram that I'll show. And then really did just a series of plan, do, study, act cycles over and over, both in the initial ED phase and are now still doing at the hospital level. And on every slide that I used a lot of PDSAs as our tool, I put a little picture of that just to remind everybody. And then moved on to sustaining. So again, our initial steps were, thinking through what do we want to do and who and how do we want to do it. And a little bit here, I'll go back and forth between examples from how we did this in the ED and how we did this at the hospital level. And again, these are meant to be examples. There are a lot of different ways to do a lot of these. And it really just depends on sort of learning and understanding the second bullet here, which is the, local baseline clinical problem, gaps, associated workflows, what will work, what will not work. I was recently talking to one of our oncology day clinics about implementing a screening huddle pathway system for their like oncology day clinic. And it was just amazing how different the workflows are there than, in our ED that is, 2 floors away. And so how different the tools would need to be. And so really tailoring it to the local needs is a huge key to success. So we started with a local improvement team for both our ED team and I will talk about in a second, our hospital team. We had a team that involved a physician, nurse, and leader in each one, plus 3 to 5 physician, nurse, and medic champions, a quality improvement specialist to guide our use of QI methodologies, and data and EPIC is our EMR, so data and EPIC support. We did a lot of work to understand our baseline clinical problem and the gaps, like the actual real gaps in care locally, as well as our associated workflows, which, in the QI lingo is called documenting or understanding your current state. And so what we learned, which was specific to us and is different than other places, was that, recognition was a key gap. We didn't have a screening tool. We had an order set and that was good, but it wasn't used reliably. We could give boluses rapidly if we wanted to, but that wasn't culturally accepted outside of a true trauma-based setting. And so we took that information, we developed a driver diagram, and developed metrics to support that. I think I'm going to try to go back and see if I can do my full slideshow here for you guys to see this one better. Let me know if I lose audio for this. So this is a key driver diagram. And so we have a global aim, we had some specific aims, and then we had key drivers, which were, we used most of the ones that IPSO suggested, but were really the key factors that we thought needed to be in place to have success. And then the interventions over here were the actual things that we were going to, test. So we knew that we needed, for example, sensitive and timely recognition, but that's not specific enough. How do we actually want to do that? Well, we want a screening tool for the emergency department. We needed a huddle tool for the hospital. We needed some education so that people understood what the signs of sepsis were, those kinds of things. So we really developed and followed these carefully over time. And then we come to screening, which I know is sort of a hot topic in the literature. We developed an automated tool that used variables that were already populated in our electronic medical record. We chose locally, after looking at our data, to focus on patients with high-risk underlying conditions that predispose them to sepsis, as well as physiologic abnormalities, including vital signs, mental status, perfusion, pulse quality. And we said that, and this is what we just set locally based on our own sort of data study, was that anybody with hypotension would have a positive screen, and any patient with an underlying condition plus 2 physiologic abnormalities. And the way we actually did that was we incorporated it into EPIC. And so this is part of just the normal triage screening that's done for every patient in as they go through triage in the ED. And EPIC automatically pulled from the neurologic and cardiovascular, and we added a variable for sepsis screening. And so people were, if they filled these out, a BPA would fire. A really important piece of what we did for this, because it was an EPIC and because huddling was new and an interruption, was we actually ran it silently for 2 months to understand how often it would fire. Here is a picture of what the nurse would see. It essentially says your patient is at risk of sepsis, call a huddle, which we nicknamed Quick Look. And so we recommended that they huddle for, call a huddle. But there was some other options if other stuff was going on. It told the nurse what the abnormalities were so they could know that, oh, this patient had delayed cap refill and they were drowsy and they had, cool, pale skin. And so when the huddle happens, they can communicate that and then put it in a note as well. And again, a really key part of acceptance of this was that we, sorry, did I lose? Someone was talking.
I think we still have you, Holly. Try that.
Okay, I heard somebody talking. Okay, a really key important piece of this, because we don't love interruptions in our ED, and maybe nobody does, was really studying and understanding and sharing how often this tool fired, because people all the time would tell me in the beginning, there were 10 sepsis quick looks last night. I couldn't do anything else. That's all I did. And I would go back and look, and there was 1, and maybe they were interrupted for 8 other things. I totally believe that. But really having the data behind the scenes to say, of per 100 ED patients, this is how many it fired on, that it fires less than 2 times a day, which is something I have said probably 1 million times to 1 million different people, just so people understand the sort of level of burden. And then also helping people understand, who are these patients that it fires on. And so these are our underlying conditions. And our positive predictive value for sepsis treatment was 22%, which sounds low until you think about it as, a screening tool for a rare, potentially fatal treatment or rare, potentially fatal condition. And the intervention just being that you go and examine the patient and make a treatment decision earlier. 22% is actually probably higher than most of what else we screen for in the world. And realizing that, most of these kids that you're interrupting other stuff to go look at earlier were actually fairly sick. Almost 80% were admitted to the hospital. So, a huge piece of this all along has just been, data sharing, data transparency, and education around, the what and the why. Because when we first started this years ago, sepsis screening wasn't, well known and wasn't super well accepted. And it was why are we doing this? I recognize sepsis. Why is there even is there even a problem kind of question. And I think everybody I've talked to who has implemented sepsis screening, whether they do it electronically or on paper or with a 3-point tool or a really complex tool that I couldn't even understand where the data comes from, it kind of has the same thing where data sharing was super important. And then so what comes after the screen? So almost everybody has some type of a huddle, the goal being a rapid team-based evaluation. And this is one where really studying your current workflow and testing, I put the little PDSA icon up here, testing sort of over and over what works, who should come, how you should notify them, how long it can take, where you should do it, what resources they should bring. Really how to get to the final state that sort of works for a system. And so we tested all those different things, both in the ED and on the floors. And each floor and each unit has come to sort of a different configuration of who responds, depending on their level of acuity and their own workflow. But definitely like lots and lots of different tests were needed to figure out a way to do this that had a good balance of not being interruptive, but getting the right people there with the right stuff to do the right thing. We tested a script to guide the conversation, which was somewhat helpful. And then we tested various iterations of guidance for next steps, all the way from, see the patient and just decide to, hey, if you're going to give a bolus, either use a pathway or maybe a modified pathway to, assess perfusion using this tool, those kinds of things, just to figure out how to help people do the right thing at the time of the huddle. And then we coupled that with sort of our care pathways and our order set. So this is a screenshot of our sepsis quick look, which is what we've nicknamed our huddle in the ED, and what what happens there. It has we hung this all over the ED and put it on badge cards. It has what a patient can trigger for when the BPA fires, what the nurse should do, and then what to do for the associated pathway. And I'll show one in a few slides that's from an institution that does this entire process very successfully, all on paper, not involving their EMR at all, with equivalent and probably better outcomes. So just know there's lots of different ways to tailor this. At the hospital-based level, we already had a pretty robust huddle and situational awareness system in place before we started working on sepsis. So it was almost the flip side of the ED. They were good at huddling, but less at sepsis specific. And so we implemented it and integrated it into what we call a situation awareness concern in our MRT and our rapid response team. Notes and pages and huddles, and they have a checklist they were using for that specifically, and we integrated sepsis into that, and then again really studied how it works on each team and who they want to huddle on and what the outcome is, trying really hard at each step not to reinvent the wheel and say, hey, you have this fabulous system of huddling, and you indicate who's a watcher, and you write a note already, and you notify X, Y, and Z people, and you use a checklist. All of that is wonderful. How do we fit sepsis into that? Instead of saying, let's invent a new system for sepsis. And so really taking a step back and studying what was going on before implementing in an area really sort of helped us with our uptake. And so, then the next step, there's screening, there's huddle, and then there's, protocol, bundle, pathway, algorithm, whatever we want to call it, but some type of standardized care. And so ours, we've variously called our algorithm or our pathway. We developed ours a few years ago. We did a thorough evidence review, as well as did a Delphi, which is a tool to bring multiple experts into consensus and understand expert opinion across a number of people, and really invited, before we did this at the hospital level, sort of everybody with a key interest. So all the different clinical units, nurses, physicians, medics, advanced practice providers, we involved, infectious disease and pharmacy and lab, and really got in the areas where there wasn't a clear-cut piece of evidence, like how often to cycle the blood pressure cuff, really got the group to come to consensus on those pieces of the algorithm. And that was important, because then down the line, when people would ask questions or say, why do you do this? Or how did you pick this? Or, I don't think this is right for my patient population, we could go back and kind of discuss, why that was, and figure out how to tailor it. We revise it every couple of years. It's very interactive with our other hospital systems. I'm trying to see the piece about antibiotics. You can't see it really well here, but essentially for a number of the medically complex patients, it just refers to the antibiotic pathways and decisions that, our oncologists have already made, our GI specialists have already made. So it very much interacts with that. And again, doesn't try to compete or reinvent the wheel for any of that. And then we are also very transparent about the fact that while algorithms and bundles and pathways can help, there are times when a patient doesn't belong on that pathway or needs something different, and that is okay, and that's fine, and we know that that'll happen about 20% of the time. And just the concept that variation should come from a patient need. So it shouldn't be that, I do it one way on Tuesday and Dr. Chambers does it one day on Wednesday, and that's how we decide what antibiotic you get. It should be, based on patient-specific characteristics if they need something different. And so we've always been very upfront with that. And when we review cases and there's a case that needed something off or different than the algorithm, because of a patient need, that's always, completely fine and encouraged. And we realize that every patient is not going to fit one pathway. And so we've tried to be really upfront from that when we're talking about this stuff. And so, the pathway is supported by a few different things. Definitely there has been a lot of education that has gone on, all the way from, a hospital level sort of PowerPoint module that all providers and nurses have participated in, a ton of sort of just in time, just in place teaching developed by each unit, where they, we gave them some generic cases. They really tailored it to the type of patients they see, and used that to go, provider by provider and nurse by nurse, and say, even informally, just in the middle of the night, like the charge nurse would walk around and say, hey, if you had a patient with X, Y, and Z, what would you do? And then what would you do next? And really sort of tailor it to the oncology floor versus the neurology floor, which were just, completely different environments and cases. So lots of sort of individualized education, as well as the hospital-wide education that was required yearly, as well as for anybody who was new. As well as this past year, a really fun, innovative, since we couldn't get together in person, patient escape room. We had really wanted to do a physical escape room, but we couldn't, so we made a virtual escape room that was sort of well received by staff as just sort of a different way of learning about sepsis. The importance of an order set probably is hard to overemphasize. A pathway or algorithm or checklist is wonderful, but it's really hard to remember to do each piece of it, especially some of the pieces that are less sort of easy to remember and concrete than, order an antibiotic. Some of the things around, monitors or reassessments or those kinds of things. And so we developed an order set. We developed the algorithm first and then an order set to support it. We have a few different ones. We have one for the ED, and then our PICU, our oncologists, and our floors in general, and our GI all sort of tailored that for their patient-specific population to have the right antibiotics or to, have the right type of blood gas that is used on that floor, those kinds of things. But then really, really encouraged use of the order set, because when it's used, sort of all the pieces fall into place, and stuff gets done a little bit faster. And then we had lots of other resources, and it's been really neat to see these develop over time, because they definitely didn't, come from the leadership team. They came from different units saying, hey, we had this case, this thing happened, we missed this piece of care, and this is what we think we need to fix on our floor to not have that happen again. And so there were things like, this is just a picture of the push-pull materials, but a lot of floors had to learn how to push a bolus, and so some had carts and education tools, or got everything together in one drawer. One of our floors, this was actually our neurology floor, and they have a nice emergency response team for patients who have a seizure, because that's their emergency that they see a lot. And this is a nice example of how they took what they already had, modified it a little bit, and now have a nice sepsis response team that fits perfectly into their workflow, is very well understood by all their staff because it's the same as what they were doing for their seizures, and didn't take a ton of effort because it built on what they were already doing. And then the other piece of this is, again, getting at sort of data transparency, data sharing, and helping people both at, the individual provider level, to the division level, to the hospital level, really understand what went well, what didn't, what works, what didn't. And then each time we give that feedback, asking people, what are barriers and what can we fix? And so this is an example of Tetra Chambers. You probably remember getting these. An early email that we sent to ED, the team, so the physicians, the residents, physicians, the nurses involved in a patient care. We explained why a patient triggered. We, put what our pathway goals were. We showed some graphs over time. We showed how long it took to get to things, and gave some feedback on, these were the aspects of care that went great. This is what, could have gone better. And then asked, over and over and over, what are the barriers? What are the barriers? What do you need? How can we help? And from that, collected that data and really continued to learn that we needed, earlier access to the vascular access team, or, we needed a medic on the initial sepsis huddle, or those kinds of things. So gave people feedback, but also took their feedback to change the systems. And this is a current example. We have KPI is what we call key process indicator, where we have each floor at the hospital level reports out on individual patients that met our sepsis criteria, and gives them, they fill this out and say, did they follow the protocol? Did they huddle? Did they push a bolus? And then teams get to share with each other, no, we couldn't push a bolus, and this is what happened. That was our barrier. And then maybe another unit can say, hey, this is how we overcame that barrier. And so really focused at the hospital level on teams learning from each other and from the feedback. So it wasn't all sort of feeling like top down, somebody was telling them what to do. And so I put this here for spread. This is sort of how we did it once we moved out of the ED and into the hospital. And so, once it was a whole hospital project, we had a coordinating council with, physician and nursing leaders, some QI and a bunch of data support, because we're doing it as part of a national collaborative. We talked to them, we talked to our executive sponsor, and then each sort of unit has their own teams. And so, the teams share a lot of information. They have large group learning sessions a few times a year. They develop the algorithm together because it applies to everybody. They develop the educational materials together. They do the every other week KPI phone call together. But then also very much, it's a big complex system. The same order set, resources, and just-in-time education would not work for a floor that sees one case a year versus, the BMT floor that sees sepsis all the time and has a totally different, antibiotics needs and thresholds to send the patient to the ICU and all kinds of other things. And so teams very much, each unit tailored that to their own area. And so, what did we see? So initially in our ED work, We saw a decreased time in first fluid bolus from 92 to 33 minutes, which, the sort of the earlier you are in the work, sometimes the easier it is to have an early win. And we also saw increased in days between sepsis-related preventable deterioration. Now that we've moved to the hospital level and to units that have been doing this a while, it's actually getting harder and harder to move the needle. But what we've seen at the hospital system is we went from algorithm use or pathway use for sepsis patients from 62 to 95%, but then had a drop after some of our many COVID-related changes. And we had an improvement in time to first bolus from within 20 minutes from 70% to 81%. And then I wanted to put this out here just again to say, like, this is an example, and I've used examples of what has worked, and definitely some of the principles are really important to sort of consider and apply, like, data sharing, making sure something is tailored to a workflow, really making sure to study and use what's already in place and build on that to minimize, new work for clinical areas. But when you get down to the actual screening huddle and pathway, they can be done so many different ways successfully. Screening is starting to be published a lot in the literature. This was one of the earliest ones that was and is still completely done on paper by Salt Lake City, and they do a really nice job and have really good outcomes doing it without, ever touching an electronic medical record. This is a sort of a two-tier screening tool that CHOP has implemented that's, does require both an electronic medical record as well as a secondary screen by a nurse that has also had really good results. And then this is just a copy of somebody else's pathway. This is Colorado's. They published a two-tier pathway approach, which was kind of nice. It was kind of what Surviving Sepsis was going to say years before it said it, with the idea that, like, a sepsis red is kids in shock and they need a lot of stuff fast. A sepsis yellow, you need to be doing the right things, but maybe a little bit more slowly and carefully and thoughtfully. And then the idea that you can move from one to the other if you have to. And really wanted to put those out there to just say, a lot of this can be done and tailored a lot of different ways. And so then what's next? New definitions are underway. Evidence is always developing. Certainly there's multi-site collaboratives that are working and studying on this. And then, out there is the idea of what is the role of machine learning? What is the role of proteomics? Is some of the idea that some of these kids that do fine and some don't because of their differential biomarkers and kind of those things. But I think there'll always still be a room for quality improvement and systems-based improvement. So I think with that, I'll take questions.
So Holly, I did see on the and that could have been a screenshot that wasn't updated. What's currently happening in your camp as far as first fluid bolus? Is it still normal saline, or have you moved to lactated bringers?
Yeah, and so it's such a, so the question is, what are we doing? And the question is, what is the right thing to do? And so currently we have left it as normal saline. And the reason we have is because a couple of reasons. So lactated bringers is a little more complicated in terms of, depending on who you ask, some people feel like you should probably, completely flush versus do it separate line. Some different ways to approach it with antibiotics and compatibility issues. And then we are also participating in a multi-site study studying normal saline versus lactic acid or lactated bringers. And so there's a lot of discussion about, is it really better to use LR for your first bolus, or is there truly still equipoise on that? I actually pulled up the recommendation around it. And the official recommendation is we suggest using balanced or buffered crystalloids for the initial resuscitation, but it's a weak recommendation with low quality of evidence. And so there are definitely areas in the hospital that use all LR, and there are definitely, it's in the order set, but it's not pre-clicked, and definitely people sometimes switch to it, but we have not switched our at least ED and PICU order sets over yet. But we are doing our every other year review of the algorithm at this point, and we think we're going to put it on there as an option. It certainly isn't wrong to switch over to it. You just have to think about, depending, different people have different opinions on the compatibility issue.
Hi, everybody. I had a quick question. And Dr. Bennett, I loved your talk. Thank you. That was great. And I think, there's much to admire and emulate in what you guys did there. One question that I have, and this is partially asked from my ignorance, is, I love early sepsis screening and stuff like that. Has anybody ever looked at sort of balancing measures and counterbalances against sort of early and fast interventions for sepsis? Do people look at metabolic derangements for normal saline, or unnecessary antibiotic exposure, or other sort of antibiogram changes after implementation, or unnecessary hospitalization or anything? I'm just playing devil's advocate and asking.
No, it's a really good question, and there's a ton of work underway. And then there's always the question out there, like, if you screen and you ask people to huddle, are they going to do something they wouldn't have done otherwise? And although we say there's always clinician judgment, it probably does, in some cases push people to do a little more. We know there's, some stuff with acidosis and chloride around, lots of normal saline. There is some adult literature saying that too much fluid too fast is a issue. And there was that recent study where it was 5 minutes versus 20 minutes. And I think that included children. And there's a couple multi-site studies underway about, sort of how much and how fast for fluids in kids. So I don't think there's a definitive piece of literature that answers that, but it's definitely a risk that's out there that people are thinking about. And then when you take a step back from it, the idea that if you are doing sepsis screening and protocolized care, does that drive some of these things to happen, and how do we balance that? So yeah, and then most people who've published their sepsis screening tools have talked about, what their false positive rate, which ours is, 80%, which is the flip of that is, 20% identification for a rare condition. But this is definitely an area where we have to think, hard, both with the actual like physical interventions as well as the like systems-based and cognitive things ahead of time. Which is, I would also say, especially for a screening tool, if you're developing one, studying it ahead of time and realizing, one of the reasons we only screen kids with underlying high-risk conditions, except for the hypotensive kids, is because we just found too many false positives when we applied the screening tool to all patients for whatever reason in our situation. And so, it's a little bit tailoring it. And then I think over the next year or two, a lot more is going to come out on that, on, what are the risks of these and how do you do this in a balanced way? I think one of the sort of very initial recommendations around screening, and I didn't highlight this one, but one of the initial surviving sepsis recommendations is, you are doing screening, but at the same time, it really needs to be systematically evaluated for effectiveness and sustainability to make sure that you're not, over recognizing, and then always leaving room for, clinician judgment, and not saying you must treat everybody who has, XYZ positive screen. Because yes, that's definitely worth thinking about and worth being concerned about.
Thank you.
Holly, I'm perusing our list of attendees here, which thank you all for showing up. It's awesome to see you all on here. So we have we have a neurologist, Dr. Anderson, who is on. We have two of our gastroenterologists that are on, and one of our oncologists who are on. And so I guess I would ask you, for those populations, so we know that kids with gastrointestinal differences, kids with seizure disorders or neurologic impairment, kids who are oncology patients are at increased risk. What would your one tool that you would say, implement this so that people, when they're in their clinic or taking calls from parents at home, could use to activate the system?
Yeah, and so I think if I was going to say one tool, I would say have a huddle, like have some way that the team can get together and quickly look and decide, even if there's not a screening tool associated with it, even if it's the bedside nurse doesn't like the perfusion, so let's get the team together. I think the huddle is really actually the thing, and having some rapid way for the team to get together. And like I said, our neurology floor does not see a ton of sepsis, and so they just built off of their seizure their seizure protocol of how they quickly get a team together for a patient who's having a seizure. But I would say figure out what you have in place already, and build on that to quickly get people together to look at a patient, have a conversation, and decide what's next. Because I think it's that cognitive piece of saying out loud, is this sepsis, yes or no, and what do I want to do next, that really gets you to the rest of the stuff. Right, because even a screening tool alone without a thoughtful huddle is probably not as helpful as a thoughtful huddle.
Dr. Depinet, thank you so much for an amazing talk. And that's actually really valuable. Communication is key. And I think that teamwork that you're talking about, that's amazing. So I echo Dr. Chambers' sentiments about thank you so much for taking time out of your day. And we really appreciate this.
Oh, no, I'm happy to, it's sort of something I'm passionate about. So thank you. Other questions? I'm happy to send out some references. Again, I would, if you want an update on just sepsis in general, I would look at that Surviving Sepsis website, read the executive summary while you're on some downtime on a shift, and it's amazing how quickly it summarizes sort of all the most recent thoughts. So.
All right, well, thank you,
Thank
guys,
you.
Dr. Depinet, and anyone who has been moved to tears about sepsis by this talk. We are launching our sepsis improvement team. John Schweitzer had already volunteered to be on that. If any of our ETSU pediatrics people want to be on, if one of our subspecialists want to be on, I think I can get you a seat, but you have to act fast. So thank you, Holly, and thank you, ETSU/Niswonger team, and have a great day.
Thank you.